Emma, Annette, thank you very much for joining me here today. Really excited to take a deep dive into all things private hospitals and the private healthcare world. Emma, maybe you could start off by doing a bit of an intro.
Yeah, thanks, Michelle, for having us. So my name's Emma Linden. I'm the CEO of Adelaide and Glenelg Day Surgeries. We're part of the Cura Group, which is a national day hospital organisation. Whilst we do have some overnight stay facilities, essentially it is private day hospitals.
And Annette Nielsen, I'm the CEO and Don of Stirling Hospital. So we're a small independent private hospital located in the Adelaide Hills.
Fantastic. And I'm Michelle Warnes, the Accounts Director for Personify Care across Australia and New Zealand. So a bit of a fun fact, I suppose. We've all sort of known each other for quite a while now, I think. Emma and I particularly, my old boss.
Correct.
So I did work at Adelaide Day Surgery for, I think it was about 9.5 years. We had a lot of fun there together. I had a special interest in pre-admission. I think I was sort of had a real passion for that space. And funnily enough, that's how I found and discovered Personify Care, which is the role I'm in today. And Annette, I think we've just been talking for years, and you've been talking to Ken, and my CEO, for years as well, and are very familiar with the work we do, and we're familiar with your hospital and the amazing work that you do as well. Here in Adelaide, everyone knows a lot about, the private world, and everyone actually collaboratively works quite well together. So it's a really lovely community that we can share lots of insights and information. So, yeah, thank you for coming today. So I suppose as a bit of an outline, I think we've had lots of chats about this, but it'll be really good to unpack a little bit about over the years where the private health sector has gone and where we are at today. I think probably what's number one in the front of our minds at the moment, and being having previously been a frontline worker and still sometimes do the odd shift, staffing challenges has been, big, a lot, and obviously across both sectors, public and private. But I think I've definitely heard and seen a lot more challenges in the private sector. The theme has come out of conferences lately where staffing retention and attraction has been a big challenge and a big problem. Maybe, Emma, did you want to start sharing where your experience has been there and sort of what you may have done to overcome it, or where you're at now?
Yeah, I guess, from a management point of view, I've been managing in a couple of hospitals at Calvary initially, but also here at Adelaide Day for the last 10 years. And pre-COVID, I would say we had a fairly stable workforce. It sort of flowed, and we had a lot of permanent part-time people. Yes, we sort of managed our shifts and had longer and shorter shifts, but day hospitals, for a lot of people, it meant that it was Monday to Friday, no on-call, weekends. So, the shift changes. People were happy to trade that off because, you had different volumes coming in, different days, and that was okay. And I guess COVID hit, and I think for the first time, nurses were really, becoming in short supply. They were spread out a lot further. They had, trying to find work was sometimes, not all hospitals had, benefits paid to staff and to the facilities. And so I think people sort of started then looking, seeing what was around to provide that security. And so I guess probably for us over the last sort of 3 or 4 years for us, we've noticed more of a change to people going digital. So there's different benefits in different hospitals. So they might do 2 days with me because they like day surgery, but then they might go 2 days somewhere else where there's salary sacrifice and free parking, or they like to do certain specialties, so they'll just work within those spaces. So for us, it's great if you can offer it. It does provide challenges though, because not everybody's available on the days that you want them, and it's harder to roster. So yeah, from a staffing perspective, that's probably one of our challenges, and then that comes down to then skill mix. So you need, in small facilities, you need to be able to upskill and have people across, lots of areas. So I guess for us, having 3 hospitals in Adelaide now under the same cure group, we have started to work on people working between sites if they're happy to do that, and that does facilitate when you can't get agency staff or sick leave and shortages. So, but I think that that casual workforce is a lot, I don't know, I guess Annette, you'd agree, broader and a lot more consistent than it has been in many years.
Yeah, because I think staff are confident they can get shifts, you know.
So they can be picky and choosy.
They can be picky and choosy where they want to work, you know. And at Stirling we have traditionally had a very stable workforce, and we're very fortunate that we, I guess, have retained that. But certainly through COVID, you know, staff did work around and help in other facilities. You know, we did the immunisation clinic with public and those sorts of things. And I think work-life balance became really important to staff as well. So we saw a reduction in permanent hours and, you know, more people looking at casual as an option and being more selective. So at the hospital, we are now only Monday to Friday, but we have overnight patients. So staff still get the flexibility of weekends off, but we still have on-call and those sorts of things, which are a little bit different than the day surgery. So we've been fairly fortunate. The challenge we have without having other sites, of course, to call on for staff is that, you know, when we get staff who are run down and get sick, we don't have anywhere to pull from. And generally it's at this time of the year when a lot of people are unwell, so the agency is also unable to provide staff as well.
So that makes me think, in those situations, when you do enter a situation where you are short, what are some of the things that you would normally do on your day? What do you go, okay, well, we're short, where do we start cutting back? And what gets missed? What are some of the risks that you think might be associated, particularly in that challenge with staff being selective? You're still having to service your organisation, get the list done. You want the specialists coming to you and you want full lists, but you need those staff to staff them. Where do you pull from or where do you cut back?
So I guess for us, patient safety first and foremost and operating lists are key. So our focus goes into delivering that service, and so then we would pull that admin support perhaps where you are doing some of the pre-admission and post-discharge work. Those things sort of get put to the side. Audits and those sorts of things certainly don't get done when you are needing to do patient care, because patients have prepared themselves mentally. You know, the carers have had, you know, their leave booked and those sorts of things. So where possible, you know, you want to get those patients done and having their operations. So that's probably, and having staff who are multi-skilled, like Emma said previously, is critical in small organisations because, you know, you need to be able to pull staff in for different specialties. And if you don't have skilled staff who can do that, then you are at risk of having to, you know, reduce that list or, dare I say it, cancel. You know, which, you know, you don't want to do for the patient or the specialist.
Yeah, it's definitely a last resort, you know. You don't want to be cancelling sessions. There's too many people involved in that process, not just the cancellation, the disappointment, you know, surgeons losing, you know, faith and also, the patients just being completely inconvenienced. Look, we're the same, you know, those admin type roles that nurses would generally partake in, you know, those pre and post-op phone calls, or sometimes they're done, dare I say it, later in the day, which is not the time to be doing it because you can't get
patients calling you saying,
no one's rung me. And also, you know, what do you do if there's an issue? If it's for the morning and it's 4:35 and you can't get onto the rooms or can't get into a doctor and they're wondering why you've done this so late. So, I agree. Those are the things that we would pull back on. I guess the other thing is, you know, managers end up getting pulled in. I mean, I'm a CEO, but I've still got my registration, so it's not uncommon for me to have to jump into, you know, recover a patient or do some anaesthetics or whatever. In a small facility, you do find yourself or you're staying back, you're covering that other end of the day. It might be a really long day. You might start there at, you know, 7 or 8, but if someone calls in sick or someone has to go, you could be the person who's still there at 7, 8 o'clock being the close to make sure things are done. So that sick leave does impact on on your well-being and managing across that whole day.
So I think that lends itself quite nicely into one of the other topics I think we've previously discussed around patient screening. So I think more and more as well that change the onus of the responsibility of that. Particularly in the private world, it's really crucial to get that right in the private sector. As you mentioned, if you're a standalone facility, you don't have a lot of other resources or a HDU or an ICU to pull on. So the criteria for those patients to come to your facility is really crucial that you get that right. What are some of the things that you put in place to work with that, and is the onus, how much onus is on specialist rooms, and then versus what you do at your facilities to kind of make sure that your patients are fit for your facility, and to ensure that you obviously have a nice flow on the day of surgery?
I think it's critical that the specialists know what your admission criteria is. So, they are picking the patients to come to your facility. So it's really important that they understand that. And I have to say that, our specialists are great at that, and I'm sure yours are as well. The last thing you want to do is transfer a patient, unnecessary. If you could have prevented that, then that's what you want to do. So, the specialist knowing what the criteria is, and then, of course, patients completing their paperwork or online admission as soon as possible gives the staff an opportunity then to review their risks. And each facility has their own risk criteria and what they're happy to tolerate and not. And then getting an opportunity to look at that, like Emma was saying, on a busy day, sometimes that can be left till quite late. We're fortunate that we do have Personify, so once the patient has completed their online admission, anything that we've determined is a risk for us is flagged, and we get notified of that straight away to our pre-admission department, and then they can follow that up, then notify the specialist and the anaesthetist and those sorts of things, which then helps, of course, the patient flow on the day, because you want it to be planned and organised, which we've talked about. You don't want to be cancelling patients the day before or the day off. We want the patient to have a great experience. We want the staff to be well prepared in the operating theatre. We want the specialist to walk in and go, yep, everything's good to go, and the anaesthetist as well.
True.
But you don't always get that right.
No. And sometimes you can't. Sometimes there are little surprises that
absolutely.
You can't.
So I guess that's what, we do around that for managing. And the other thing, sorry, Em, is that, risk assessments have changed over the years as well. So, with the introduction of the national standards and those sorts of things, there's a lot more screening tools that organisations need to do. And I think all of us would agree that they're great tools that, we need to do to review and assess patients. But it's a lot of time.
It's time consuming.
Which, you don't see any bang for buck for that, from a management perspective, but it's critical for the patient's experience.
Yeah, I did a shift, I won't say where, it was a great shift last year, and it was purely in admissions, and I was just admitting a urology list. I was blown away by how long it took me to admit. I think it was 8 patients on a list, and I had one list. That was my role at the time. And I think, it took me maybe 35 minutes.
There's no shortcuts anymore.
per patient. And some of them were quite frail. Obviously, they needed assistance with getting changed into their gowns. But to go through all the frailty screening, all the pressure area cares, the delirium assessments, there's a lot of stuff. And they were going, wow, you've got a lot of paperwork there.
I think the challenge with that is, though, I think the guidelines and everything come out as like a bit of a bucket. It's a one-stop shop. This is it. And it takes a little while to work out what is relevant, what you can not get away with, but what is required for, say, a day hospital admission versus an overnight stay of, 3 or 4 days.
Absolutely.
And there's not a lot of, there's nothing that comes out, say, from the commission or somewhere like that says, well, this is relevant for day and this is relevant for overnight. So you tend to end up having everything to implement, whereas once you start getting into it, you can start paring back things. So like our our risk assessment screening's gone through our quality manager, who's then referred back to the commission and said, is this satisfactory? So we can make it a little bit quicker, because like you said, the procedure takes 2 minutes and the paperwork takes 20. It's not efficient. So and it does lead to patients being dissatisfied during their process when there is so much paperwork. They can't see the point in it. You try to explain it. So it is a challenge within organisations.
We're actually, and this is just in that topic of screening, the public sector actually, some of the teams that I've been working with in the public sector are doing that amazingly well, particularly around pre-admission and anaesthetic departments, where we've actually built in some of those evidence-based screening tools around the DASI score and the stop bang and those risks, and into some of our digital pathways, and put the scoring alongside some of those responses. So being able to flag to teams ahead of that, wow, this patient sits in this section, or they're a high risk here, or they're a frailty risk, has been really helpful for not only triaging patients, but being able to then start to look at staffing early. So looking ahead to be able to go, oh, okay, so on Thursday we've got 3 high frailty risk patients in, we're probably going to need an extra person in recovery. Having that visibility, I would imagine, from a staffing perspective, or actually it's these patients are all fit and healthy and light, let's cut back, we don't need one there. So
certainly if the patient can be filling out that information, which they often are on a health questionnaire anyway, if those questions can be built into those screening tools a bit, and that just transfers over into that, and then you are literally just looking at the results to determine it. It would make that admission day process a lot more efficient.
Yeah, so our admissions are a lot more efficient now since Personify, because the patient has filled all of that information, and so you can quickly look and see, well, where have they scored and what do we need to do here? So you're not having to sit there and unpack every question with the patient.
Particularly in day surgery, it's probably, not to say not relevant, but they are there for such a short period of time. They're going to be considered probably a high falls risk anyway.
They're not necessarily a pressure area.
Pressure area might.
10-minute procedure.
No, I mean, look, we might have that. We still do some of the, breast procedures and the larger ones, and so we still need to look at that from a pressure area perspective. But I think you would sort of cut out a lot of that by being able to have it presented and ready for that admission, and you're just confirming rather than
it's the cognitive impairment,
that you really have to do face to face
over 65.
And interestingly, just on the topic of technology and across the board in your organisations, how have you seen, look, we commonly hear, oh gosh, my staff aren't going to want to do that, or my patients won't want to do that. How have you seen the adoption of technology in your organisations amongst your staff and amongst patients for
it depends what it is.
Purposes?
So like we've introduced a tracking system for our CSSD, it's one of the standards is they want you to put this electronic tracking system in, which we've done. It's great, but the system works really well if you've got a fixed desktop computer, but in a theatre you need to be mobile, so trying to translate that into some sort of workstation on wheels. So we've been putting in laptops. Well, sometimes the laptops, it goes blank. You need to re-log in your password. So I think with nurses, if it doesn't work straight away and you can hit it with one button, then we hate it. So I think with technology coming in, I think it certainly has its place, and it definitely can make some things easier. And from a manager, when you can pull off data and track things, awesome. But if it's not user friendly at the staff level, you're not going to get accurate data, so it's pointless. But look, lots of things have come in. We've had credentialing for surgeons has become electronic, and then you've got platforms like your payroll systems, and a lot of them have come in. Even uploading to the My Health record now is another thing that you've got to do. So I think everyone's fairly used to it. I think the challenges are not just implementing it and what is still needing to be refined, and then continuing with that. I think sometimes we get a package and we think we know what we need, and it kind of works. And then if we don't keep on it, it either just everyone's just annoyed by it and goes, has a negative perspective of it. So or you get it sorted and it works well. So
I think implementing change is always a challenge, particularly with staff who've been doing things a certain way for a long time. So when you want
clinicians are particularly
they don't like to change. But you've implemented things and so have we. And I think one thing we've learned is getting the staff buy-in before you implement anything. And education is key. And they need to know what the benefit is for them. Once they can appreciate the benefit, I think they work much harder to navigate a system that, they wouldn't ordinarily be happy to do. So, I thought when we implemented Personify, I thought the pushback from even patients was going to be much more difficult because we've got an old cohort of patients in the hills. But over 90% are doing it all online, and I never thought we would get that. Which is fascinating. I
think it's another COVID drove technology for everyone.
Well, that was everybody's ability to communicate. So, you do have people in their 70s and 80s with their iPads on what do you call it? FaceTime and talking to each other. So, you know, that was communication. So look, I agree. We have a procedure, the intravitreal injections that we do, and obviously everybody within that bracket is, over 70 plus. And there's always, oh no, they won't be doing electronic forms. So annually we were getting them to fill out these paper forms, and we've, encouraged them to go online and do it. Now annually they just check it and tick a button and tick it and say that it's correct. So I think we're not giving that population of people enough credit and respect that they are, and some need help for sure. But majority, I think, are pretty savvy. They've all got mobile phones.
I just touched something you touched on earlier, Em, around data. So how important has data and information become or come to you, sort of particularly over the years? I know that you mentioned auditing before, and obviously with accreditation, short notice. Data is crucial to driving efficiencies, but also to being able to prove the work that you're doing and manage some of the standards and some of the pieces of information that you're working towards. And I think you also mentioned, I just remembered previous chats around registries as well.
Yes.
I'd be interested to hear your thoughts on that.
Yeah, so look, certainly data is, as a national organisation, we've got, a whole quality program that we need to report on. And, there's our internal and then there's our external that we do for benchmarking, etc. So getting that data and being able to have it and get it quite easily is really helpful, because otherwise, I think a lot of time you do audits, then by the time you get it done, then you're just going on to the next one. And do you really look at what that means? So having that time, having that data and getting it easily so you can actually track your trends is really important. I guess particularly around if there's, certain, risks that you're seeing a bit of a trend in, etc. As for registries, look, we do a lot of breast procedures. So there's the breast device registry that's out there. Most people, subscribe to if they're doing these certain procedures. But there's also lots of clinical care standards where you need to be looking at certain procedures. There's, antimicrobial stewardship and what antibiotics you're using and how you keep that data. So there's, and a lot of that you're looking at regularly, monthly. It's not something that you do once and it's annually.
Patient files?
Patient records, We're very manual still, so we will get a script that goes with the file, and the staff photocopy the script and put it in there. So when we're going back and doing an audit, we're not trying to navigate what they might have been sent home with, and that can be labour intensive. So some audits, they do take up a long time. Especially when you've got to do, if you've got a lot of patients coming through and it's a percentage of your patients required. Any way that you can facilitate. Adelaide Day also completes the sterilising for Glenelg Day surgery and facilitates others in our building. From a tracking perspective, we need to be able to see, well, how many trays are going out, what loan kits are coming in. So we can actually look at our staffing in CSSD. Are they under pressure? Because the patient numbers may not, which is what you tend to do your staffing around, may not reflect what is actually coming into the business.
Caseload.
Particularly with things coming in from anywhere to then be processed to go out to Glenelg, back and off. So yeah, it's really handy to have all of that loss of instruments. Where are they? Have we processed them? Things end of life. So you can actually prepare your budgets for CapEx that might be required. So, being able to track that and know what your inventory is instead of, guessing is valuable. Yeah.
Yeah. And have you found that too, Nat?
So one thing I was just thinking about when you were talking about registries and things was like incident management and quality improvement registers and things like that. Again, looking at trends and those sorts of things, it's critical for, your not just your accreditation, but, looking to improve practice or look at areas where, you could be reducing costs, and you can look at that through those sorts of registers as well.
Yeah, and technology obviously plays a big role in that.
It does, yeah. And having, again, so that's training staff, so, I'm sure you've got an online incident reporting system as well, and, getting staff involved in completing that and doing that and then showing them what happens after they've done that, I think, and closing the circle is really important, because sometimes they think, I'm just putting it in there and goes off into wherever. So, we make sure that, you sort of close that gap and bring back, what happened when you entered that in and what improvements have we done, or, what happened with the patient, those sorts of things.
Yeah. And from a business development perspective, sort of slightly moving it a little bit, we were talking about sort of, when it comes to being in the private sector, being standalone, there is a lot of competition out there. And what are some of the challenges and some of the sort of things that you think, are really important to have in your facilities that can help you stand out from other facilities? I know we talked about patient safety, patient experience. How have you seen that change over the years, and what are some of the things that you think are really important for you in your organisations to sort of, obviously say, well, this is what we do and these are some of the things that we're working towards to sort of maintain our organisation and show that we, we are providing the best care available, particularly in the private world where there are a lot of similarities to organisations and specialists can pick who they want or where they want to send.
Or your locations. For us in the city is very close. You might have, 10 other hospitals within a 10K radius of you. Yeah. I think for me, there's lots of aspects to it, but I've always been really passionate. If you don't have your staff on board and they're not engaged, they're your greatest marketing tools. So, empowering them to be, high performing and resilient and, being alert and having that situational awareness, understanding that, they are leaders on the floor. Doesn't matter whether you're a first year nurse or someone who's been there for a long time. Everyone's learning from each other, and I think if you've got that cohesive team and everyone's enjoying, working together, not without its challenges, I think, patients pick up on that and they appreciate that environment. It comes
back to the patient in the end, because their voice is loud.
It is. And, they want to see people enjoying it, but also, asking the right questions and, not necessarily just reading off a sheet. They want you to be engaged.
Yeah, where it comes down to that phone call, that pre-admission call, that the nurse is tired, they've had a long day, they're understaffed, it's 5 o'clock, they want to go home and they've got to pick up the phone and call 10 patients before they go.
Yes.
Just to check in on them.
Well, and nothing's worse than a patient's filled out all the paperwork and the nurse says, do you have diabetes? And it's like, well, hang on, have you not? I've just ticked that 25-page form to tell you that I have. One of those is yes. So I think, sort of training your staff to try and make it a bit more of a conversation, particularly as we're going through still the entire health questionnaire. It's not screened for us. So trying to make it that, the patient gave us that information, and thank you for giving us all that information. And then understanding how to unpack that a little bit more. If they've ticked something, like they might say, no, I don't have high blood pressure, but that's because they're on blood pressure medication. So, you know,
it's
so it's being, you know, having that awareness.
And also having all your staff on the same page with that. Correct. As well, isn't it? Because you can have some that are really aware and can really pick out those things in a questionnaire, and some that are quite new and not as experienced.
Yep.
So the standard of screening between staff members when it's done manually can be quite different.
Varied.
Varied.
Yeah, and I think that's, so from a pre-admission point of view, I think having some key people and probably something that when you are busy, you don't get back to them as often to see, you know, how people are doing it and how they're going. So I think that's probably something that, you know, we're looking at within our organisation is, yes, we're training them, but then, you know, going back and
checking in.
Well, something that came up today, just incidentally, a patient was on a public list that we do, and so the staff have rung the patient to give them their admission time, etc. But there's an interpreter that's booked for them the next day. So if the patient hasn't answered the phone, it's potentially they don't speak English. So, you know, we should have been ringing the carer or the next of kin or the contact, you know, but obviously, you know, someone hasn't really thought of that. They've been rushing to get it done, just rung the patient, left a message, and of course they didn't turn up today because they didn't think
get the message or
they didn't understand. So I think it's when these things come up, then having a chat to everyone, how could we have done that better?
How could we have done that differently?
So that was just something I put out to everyone today. Maybe they didn't understand the message.
That's interesting, the public in private as well. Obviously, that's something that's done more and more across the country at the moment. I'm seeing that a lot. And, having disparate systems the way we do across private and public, you know, if you look at SA all being on a statewide EMR, you know, the privates don't have that luxury necessarily or have access. And it's interesting, something that I see a lot in talking to a lot of my customers, particularly in the private world. I have a lot that, you know, we chat about what their needs are, and quite often they ask my opinion on, do you know of any EMRs or any digital medical records that are sort of fit for purpose for private or day hospitals that are smaller and don't actually, you know, can't afford those big EMRs. So I definitely think that seems to be quite a gap at the moment in sort of that communication piece for public versus where the privates sit. I don't know if
in terms of sharing information.
Sharing information. And I just think, you know, the private do seem to be not quite, you know, don't have that same data capacity.
But they probably don't have the budgets.
We don't
and
have
the budgets aren't there.
It's the budgets.
And that's where we sort of seem to circle back to and trying to understand. When we partner with a number of providers, and we have found some in that space that we can work with, but there's not a lot.
There's not a lot of margin in health, I guess. No. And, you know, most people who understand the private system, you know, hospitals essentially are not in a position to charge over and above, you know, what the health funds provide them with, you know, as funding. So, look, there are certainly hospitals that are financially probably having to sit and look, you know, I've got to upgrade equipment, or do we put in an electronic medical record, or do we, you know, and I think trying to work through what the financial and time benefits are, I think as a business case it would be really challenging to do unless, you know, like you've probably done with what you've done with your pre-admission, you couldn't probably see a saving pretty easily. But as in terms of you know, an EMR that goes through the whole facility, that might be harder to try and sort of come up with, because there might be hidden costs that you're not aware of, and
it's not
IT considerations.
Just a software program for an older facility like ours. You know, there's the whole infrastructure that goes with just the program, and that wouldn't be simple. So, you know, that's probably why a lot of private hospitals who are older just haven't even gone down that, because you have to prioritise where are you going to invest, you know, your money. You know, you need the doctors to be coming, you need to have current equipment and those sorts of things.
Facilitating end of life or things that just suddenly break, and it costs, you know, $14,000, you know, or more.
And things that you can't go without.
Well,
essential items.
Essential items.
Yeah. And the other thing I think too is, from a financial perspective and a challenge is we're having to preempt a lot now because like companies just don't have things on a shelf. So if you've got instruments that you need or something breaks, you're often buying more than what you need because it actually can take over 6 months. Sometimes they don't even start making them until you put an order in if it's a specific item. So you're sometimes spending more money when you're going to buy something because normally you might buy 2, but you might buy 4 because you just don't know, and if something breaks you just may need to get that in the future and it's going to take too long. So unless you can borrow from somebody, and I guess having 3 hospitals in our group who do similar specialties, we can help each other out and borrow. But I can only imagine, and look, obviously if Annette rang me tomorrow and said I need something, I'm not going to say no. And I think that is a beautiful part about Adelaide is we're all in competition, but essentially we're collegial and we're going to be supportive of each other in a crisis. But it is something that you're constantly thinking of, and when you're doing your strategic planning and trying to budget, you're looking at the next 3 to 5, but something could go wrong in that year. So but what do you trade off?
But it's so tight right now.
But it's a trade-off.
It's tight
not.
Now.
It's really tight. And when you top that with staffing and salary increases and, consumable increase pricing went through the roof post-COVID.
Services, electricity, gas, all those.
It's huge. It's really huge. And it's a very tight margin, which I think a lot of, staff working within the facility, you don't want to talk about that all the time, but they don't see how challenging it can be to be keeping that business functioning and running so they can come to work every day knowing they've got their own mortgages and their own challenges. I try to tell them it's like budgeting at home, work is like that. I'm like the parent that has to be responsible for all the money because the kids still want everything, but I kind of have to. It's the same thing, treating your work a little bit like you would at home. You still only get that same paycheck each week. We're the same from health funds. We still only get that same amount of money each time.
Yeah, and on that, I mean, there's obviously, everyone's aware of what's happening, it's talked about a lot in the media at the moment and where things are at with the private sector. I know you're both involved in APHA and you go to meetings. Is there any insights is there discussions around, do you see?
There's certainly discussions.
Do you see any reprieve? Like, is there... Oh, God. Are we coming to a point where something's got to give? And
well, I think a lot of it hasn't it? Like I'm not going to talk for other organisations, but obviously what's been in the media, there's been, HealthScope have been challenged, and I think what we don't see though is those that are sort of haven't folded yet, but they're really up against the wall. And there's a number of hospitals that are in that position, and it's really hard because it's not necessarily mismanagement or something nefarious. It's literally the environment, and I think nationally there are hospitals that have closed. A lot of regional hospitals don't provide services, and I think we had a meeting just recently, and there are hospitals that have changed the services that they provide. There's some in Adelaide that don't have a cardiac centre, that don't have maternity, or they've moved.
They have to disinvest.
So it may not be they've closed.
That's the sad part about that. In the end, it's about the patients, right? Isn't it? So absolutely. We know that the public sector's got its own challenges with wait lists, etc. So if the private sector can't service and facilitate because they're shutting down for a variety of reasons, then where are the patients going?
They're just pushed back into the
public sector. So really, it's in every private hospital's interest to work together to collaboratively try and work out how that's gonna how we're gonna sort of keep them going and stay alive and open and work smarter, not harder.
Well, the landscape's changed around that too. Like, I don't know about you, but like we didn't do really any public work before COVID, and public contracts would sort of come to some of the bigger hospitals or come their way, usually around Christmas time, you'd get a phone call to say we've got all these patients to get done, and there was some work done between the public and private sector to try and make that a little bit of a smoother process. But certainly now a lot of hospitals are starting to help and facilitate where they can. But look, I just think there's still challenges around the public sector, how they get out to hospitals, and then what you can safely deliver in your private hospital that works within, like we were talking about before, your admission criteria, etc.
Yeah. And the risk that, your hospital is prepared to tolerate. And I think the waiting lists over the years have probably increased because, the patients are struggling to get back out into either an aged care facility or somewhere like that. So it's sort of blocking up beds and things like that. So, the private hospitals are trying to help where they can, but, there's only so much we can do as well.
Yeah, absolutely. And but they're such a crucial piece of the puzzle, the whole puzzle, aren't they?
Yeah. Well, it's SA health. It's everyone's health. It's not, we're all part of one team, and I think everyone's looking to try and help each other when we can. Yeah. But I think the thing is, there's just not one answer. And, a CEO who's retired now, he just recently, brought out an article that was from 27 years ago that was reflecting the same concerns, and we still haven't really solved the problem. I don't know. I don't think it's, and I'm not sure that governments really have the answer either. I don't know that there's a one-step solution. No. Have we gone too far to be able to pull back? It just keeps changing, and I think you were talking about regional situations where if people can't get the support in those regional zones, then of course they're going to be coming to the city to get that assistance, and so that is putting additional pressure and a burden on the system here. And look, then do you take it back a step further to GP practices that are overburdened and people can't get appointments in GP practices, so are they deteriorating because they can't get that help? That's another whole thing. So that primary care
plays a huge
role that in the media you see they're struggling to be able to provide service to everybody. I don't know, I can't get into my GP these days unless you go on the portal and there's a 2-week wait. Sometimes
you've recovered by then.
Plan your illness. Plan it in advance if you can.
But I think collaboration with public and private is key moving forward to
totally.
Just working through the issues and looking at solutions. I think
before there's a crisis,
private are very good at looking at solutions. Because we just have to do that. We don't have an option. So
you can
very
pivot
keen
quite
to
quickly.
help.
I think you don't have quite the number of people to go through to make a decision.
We can get decisions made.
And you can. And that was a conversation that I had with them today. Just tell us what you need and we will be able to do it. So, you could make a phone call to any private hospital that morning and have a decision within an hour or so of what you could do. That's the advantage.
Has that changed much? I remember when we first started doing public and private at ADS, and one of the things I would do is look at all the RFAs that came in from the hospital that we were working with at the time and screening. I was screening the patients to make sure that, and I would say, well, we can do these, but we can't do these. They don't meet our criteria. I remember the days where they came in and one of our specialists actually sat and had downstairs and met with them all and double-checked them to make sure that they were fit for coming to our facility as well. So I was just thinking, pretty sure it's not like that now. Has that process been more streamlined now that it's been happening for a lot longer?
Yeah, look, I think those who they've got our criteria, so they just put something in and send to us. I think the relationship building between the organisations has been of a benefit. They might have, there might be a turnover of people because they get moved around between departments, but if you can have somebody there for a period of time, you can develop that relationship where they know what you need. And I think once you get that, then even at a nursing level, we've had some of the outpatients team just want to come over and have a look and see how it works. So,
awesome.
5 or 6 years later, it's, there is that relationship and collaboration, and I think that's really important. And the feedback from the patients that it is working. I mean, there was always that pushback initially. Are the private patients going to get upset?
I remember that because we had times where private the private patients were sitting in the waiting room alongside the public, and
all patients though.
There was exactly, but
patients.
there was that whole, well, are they gonna? Well, I think that was a bit of a myth, really. I mean,
look, it might have been some cases, but to be honest, it's not something that we've really had any significant concern or feedback on that's really an issue. Because those patients might have been waiting, 4 years for their cataract, whereas the patients that's private's only waited 6 weeks. So,
I remember one, oh my gosh, what we did was the cataract was so bad, they'd been waiting for like
7 years or something. So that's got to be helpful to the sector, because that flow-on effect of someone who can't see might then have a fall. We're all on the same page.
I remember actually seeing how elated some of them were, to be honest, that the appreciation of some of those public patients that came through. We're so excited about that opportunity. So, and that's what it's about in the end, isn't it? It was really lovely to see.
And I think, it's, the staff, everyone just treats everybody the same. It's not any different, but, you might find, because someone has waited for a long time, some of those comorbidities or whatever,
a bit more complex patients coming through.
Correct.
Which then, I suppose, goes back to the staffing situation that we see that, you've got to have sort of the right staff on, and you've got to staff appropriately, I suppose.
So then that goes all the way back to staffing. Is how do you look after your staff? Do you have consistent staff? And if we do have that casual workforce, potentially you lose that traction. And so trying to get us back to a little bit more stable environment, I think will be something that's really helpful to everybody, to be honest. But there's so much, competition out there. Like, whilst we're all friends, we all have different pay rates or different EAs or different things that are going to always, impact someone's choice.
Whereas public's a little bit more on the same page, really.
All the hospitals are pretty.
It's just is what it is. And there is a lot of movement, particularly in SA. I see people going to different LHNs, but it's not necessarily for pay, or it might just be to grow
an opportunity
to, to be promoted into a different role. So, but private has its different challenges in that space with the movement. And
I don't think, sort of the number of patients doesn't seem to have grown, but, there's more doctors coming back to Adelaide. I think for a long time people would train here and then head off interstate. Whereas, we've been really fortunate to bring a lot of the doctors, that cost of living in Adelaide, or the lifestyle that people, like you said before, lifestyle is something that people really value. And, even sort of medical professionals now, not necessarily starting early in the morning and then going till crazy late at night. Some still do.
That's changed a lot.
But they're wanting that family time.
When I first started nursing, be in theatre still at 11 at night, finishing off the last case versus, it's just seems to be a lot more reasonable now.
Well, a lot of their partners are also professionals, so that might be something that's different from 20, 30 years ago. So, when you've got two say doctors working together, trying to have their own careers, then that does it does change that people are having to, go a bit earlier because their partner's got a late list somewhere else. So
and there's an area of need too. And you're an area of need. Is that how you say it? Or some of the doctors from overseas work in certain hospitals. Locations,
have to be a certain away from the CBD. We don't have many, but we do have a couple. But I'll just, the work-life balance is important for them as well. If they live locally, they like to, work a couple of days where it's local. The shared parenting is really important between, partners now as well. So trying to fill your lists on a Friday isn't always that easy. We've got golf on Fridays, or we've got weekends, things like that. So it's certainly changed.
Only putting 2 patients on my list today because it's parent-teacher interviews. Like, what?
I know. So, that never happened. Like 20 years ago, that never happened.
And that's the other part, I think, I see, particularly the difference in the private and public, is you've really got to be able to pivot quick, like we said earlier. Specialists take leave and they decide they want to go on a holiday. Well, there goes 3 sessions over the next
Correct.
2 weeks,
Yeah.
and you've got staff that you're like, oh, okay.
We still need to pay them.
We still got to pay them.
Yeah.
Like so, and how do we manage? Casual helps with that. So there's a positive that, with that flexibility with casual.
But if you cancel them too often, then they'll go looking
then
somewhere
they'll go
else.
looking elsewhere.
Yeah.
Challenges in
We need
that.
to like plan it better. Yeah. No, it is hard, and but look, I don't think that's anything that's changed, and certainly, I could pretty well, say that the managers that I had sort of 25, 30 years ago when I started nursing were having similar challenges to what we're having now. You certainly don't go into management thinking it's going to be sit behind your desk and not worry about, the rest of it. So, look, I think the next, 5 years in health will be really interesting. I think, there's been, I think sort of COVID, a lot of nurses left nursing. I don't know what the
something else
stats
I was going to
are.
say earlier. I do know that was a massive part of staffing issues. Then a lot of nurses that were either close to retirement chose that was perfect timing. They'll retire, or some chose not to get vaccinated, or some just decided it wasn't for them anymore. And particularly, ED nurses, there was a lot of burnout there, and then they left after that. So
and they took all that experience with them as well.
Absolutely. But I
was a
think
challenge.
there are some that have now moved back in.
Yes.
There are some that have kind of
Which is why
back.
technology needs to be straightforward, because, I guess even just with the recent ARPRA registration process that wasn't straightforward, they introduced this new portal. I did actually lose one nurse to he just decided, no, this is my cue. He'd been thinking of retiring for a while, and that was just the thing that tipped him over the edge. Sitting there for 10 hours trying to get your registration done, whether it was him having a challenge to it, you couldn't even ring someone to get some support, to get some help. So, there is an intolerance to inefficiency or difficulty, and cut you off, I'm done. So
that's an important part with technology as well in healthcare, in the capacity to get support when you need it. I think there are times where it's quite critical. It might mean, how to progress a patient or how to move forward. So,
or having local support, not necessarily someone on a phone to give you instruction. You can,
or take a ticket and we'll get back to you in a couple of weeks.
You can
couple of weeks.
You can unpack it so much quicker if you can have someone come to site. So vendors, for me now, if there's not someone local, but even for purchasing of equipment, etc., if you can't get local maintenance or local support, unless I really need it, I tend to steer away.
Interesting. Yeah, that makes complete sense. Yeah, absolutely. Well, we've unpacked a lot. I'm not sure we've solved any problems, but I think, look, there's lots of positives, I think, in what we've discussed today. I think, I do like to touch on the collaboration between public and private, and really I can speak for SA mainly. I do speak to and see a lot of teams across the country, but obviously knowing very closely SA Health and the private world in SA, I do think that that's something that we can really say is for the greater outcome of the patient right now. I think that's kind of, as you've mentioned, it's been more streamlined. The relationships that have built between SA Health and the private world are quite strong now, and knowing what each site needs and what you can do to accommodate. So I think that's a real positive outcome in how the two health sectors have, collaborated and come together. As we've also said, there's some challenges across the differences between the public and private and the funding models, and I think public also have tight budgets, but I think in the private world it seems to be a little bit more obvious how tight that bottom line is, and particularly when it comes to staffing and getting either something that is an essential item versus something that would be really beneficial for your business or for your strategic plan. So it's making those really challenging decisions. Back to staffing, I think it's been interesting sort of watching and listening to how things have changed over the years, with permanent part-time and more sort of consistent to now more of a casual approach, and maybe we're coming back into something a little bit more consistent again now since COVID. What probably I'll throw to both of you, maybe Annette first. Do you think what's sort of one of the biggest positives changes that you've seen in the private world over the years, particularly something that's impacted your facility and how it's working now, and what's something that you'd maybe hope to see kind of moving forward?
Something positive in private. Lots of things. I think particularly since COVID, the open communication with specialists and for me, transparency with them around the business operations and how we can improve efficiencies so that the hospital can be sustainable. That's been a real positive. And also with staff, engaging with them and bringing them along. The hospital's had challenges in the past and we're, really progressing in a positive way, and seeing the staff get involved and excited about the future is really positive. For the hospital moving forward, watch this space. I think we're the only private hospital in the Adelaide Hills, we're sort of the last point before you come down the hill, and there's lots of opportunities for the community, and we've seen a lot of growth in the last few months and community getting engaged. So we want to build awareness in the community of the hospital so that we can maintain our service, which ultimately takes pressure off of public, but also is a choice then for the community in the Adelaide Hills and absolutely. Certainly the eastern suburbs as well. So absolutely. So that's exciting.
Exciting times.
Yeah, no, I must admit I was just thinking one of the exciting things was actually seeing, Stirling Hospital was really challenged for a while there financially, and Annette has certainly put a lot of effort into that, which, I know for a fact that she has, and actually just seeing that hospital sort of starting to grow again is actually really, that is positive exciting. For the rest of us to see, because the community did get around that, and I mean even as far as a quiz night or whatever that we all attended to support. So but I think that just shows the cooperation and collaboration in SA. I think it's unique, and look, there is so much more that can be done, and there are certainly, you could go on all day about the things that could be done better, but I think for me, knowing that, it doesn't really matter which hospital, I was to probably call on to say something's broken or I need help or, something like that, you will get that support and you know who to go to. And I think that's unique to SA, which I think is really important. I think we all have, like I said before, that healthy collegial competition, but there's some mutual respect around some boundaries, because we all, like staffing, you would hope someone's not outwardly going out there trying to, grab your staff, because it is going to have an impact. So we're all really mindful of how that works, because you need that help when you need it.
Yeah, I think as we sort of spoke about earlier, the more hospitals that stay open in the private world, the less pressure is on the public sector. So in the end, it's for the benefit of the patient and, across the board. And we are all going to be patients, or maybe have been one day. So, it really, that's what it's all about.
Yeah, correct. Yeah. And look, there are lots of things we need to improve, and there's certainly going to probably be hospital closures or people who are going to have to change services, and my hope will be that we can, whatever the solution is, whether it's, government, state, federal, etc., that it doesn't drag on, for too long, because there are particularly for those regional areas, they're really suffering, and I'd like to see that, things can be done to sort of help that, if that's possible, or what are the solutions within the city that we can all work towards to make sure that everyone gets that care that they need. But look, certainly it will be interesting over the next few years, and I don't know I don't really know what that looks like, but let's hope everyone can come together and solve some challenges.
Watch this space. I might even do a shift or two at both of your organisations just to
signed up.
Do my bit. Just to help out.
I'll just get that.
That's actually now recorded. So.
Fantastic. So, look, thanks both for joining me today. It's
Thank you for having
always
us.
a pleasure to chat to both of you. It's a lot of fun. And let's watch this space. I look forward to seeing what the future holds for both of you and the private world in SA.
Thank you.
Thank you.